Welcome everybody to our panel on how the global pandemic is reshaping health insurance in America. We're going to start with a little bit of introductions. We have some distinguished panelists today with Stephanie, Adolfo, and Frank, and each one of those guys are going to do a little bit more introductions on themselves. So starting with you, Frank, do you want to tell us a little bit about yourself and what's going on in your world?
Sure, I'm Frank Dominguez, President and CEO of Paso Health. Glad to be here in this panel and in this ever-changing landscape of how healthcare is delivered. I think this topic is important not just for us as health plans, but for any stakeholders that are interested in how this episode has changed the way we practice in health plans and how the collaboration between providers, the state, and of course our partners will change how we view medicine going forward.
Excellent. Well, thank you, Frank. Stephanie, you want to go next?
Sure. Hi, I'm Stephanie Rogers. I'm the Vice President of Government Programs with Scott and White Health Plan. We are part of Baylor Scott and White Health, which is a large integrated health delivery system here in Texas, about 49,000 employees, a little over 7,000 physicians. Our health plan currently covers South Texas, West Texas, North Texas, and Central Texas. And I'm happy to be here today. Thank you.
Well, thank you, Stephanie. Adolfo, you're next.
Great. I'm Adolfo Valdez, the Chief Medical Officer for the Memorial Hermann Health Plan. And much like Baylor Scott and White, we also are a large integrated healthcare delivery system with the Memorial Hermann system serving the greater Houston area. And we have a number of inpatient facilities, outpatient, urgent care facilities, as well as secondary level of care facilities, skilled nursing facilities, and LTACs. And so we have also a health plan attached. And as working together with our providers, we've certainly seen an impact across the system, including our health plan with the pandemic.
Excellent. So just to round it out, my name is Nathan Funk with Optum's Advisory Services. I'm a Senior Vice President here. I run a government consulting practice. We pulled together these distinguished panelists because we think they each have unique viewpoints on this topic. We're going to jump right into questions. So next slide, if you could. You can't have a panelist discussion without some trending topics and some word art. So just a little bit on what was out there when we talked the first time and how often some of these topics came up. So interesting topics, may not hit on all of them today, but just a little bit on kind of what the background was. And jumping into the first question, so I'm going to give you my best game show voice here as we jump in. So in relation to COVID-19, what has been the biggest impact to your organization? I think Adolfo, will start with you.
Well, I appreciate that. I think the biggest impact has to do with probably us being the smallest plan. We're a small health plan, just at 20,000 members. We do a lot of work in the commercial space and Medicare Advantage space. And certainly the pandemic hit us in multiple ways. I think at least three ways. We can certainly on the clinical side with utilization and impact to our membership directly. As you know, Medicare Advantage by definition will have elderly adults with multiple complex chronic conditions. And so they were a prime risk group for this pandemic and certainly bore the brunt of the pandemic. In addition to that, though, from a clinical perspective of higher utilization of acute inpatient services, intensive care, higher intense resources such as ventilators and even at times ECMO, extracorporeal mechanical oxygenation, high utilization of high cost services, and then prolonged lengths of stay at both the acute level and the secondary levels of care. So we saw a big financial impact as well from that. And then lastly, operationally, I think we saw an impact because we're a small plan, we're provider owned, we're actually located on one of the medical campuses. I think our business was used to being in person, face to face, and having to quickly shift to almost or near 100% remote workforce. Put a challenge on our business continuity plans, but we were able to maintain it. So I'd say it was in those three areas of clinical utilization, financial impact, and and operational impacts that it really affected our health plan.
Makes a lot of sense. I appreciate that, Adolfo. Stephanie, what's your perspective on this?
Sure. So a little bit similar to what Dr. Valdez mentioned. We, really initially had a big focus around communication, driving clarity with both members, consumers, and providers, and planning with our members. And so, making sure that we had appropriate outreach to ensure that members had access to care, understood where they could go for resources, help them identify and manage any risks associated with COVID, especially that population that Dr. Valdez was referencing as well, that's sort of the higher risk group. And then also, working with members to help them adapt or transition any ongoing services to telehealth or home-based care where appropriate. And then I think the big thing, obviously digital, right? So this has sort of been a catalyst for all things digital and telehealth. So we've had a big effort just to scale up a digital and virtual care offering across the market.
That makes a lot of sense. That's a great response. I don't know, Frank, anything else you want to add on that? Something else you want to touch on from the El Paso side?
Yeah, I think from the El Paso health perspective, and for those of you, familiar with El Paso, we're far west Texas and really the only city that is in mountain time. So I think we have always viewed ourselves and I think the other health plans that participate in this area as the area that has to kind of fend for itself because we're far off from everything else in Texas. So the pandemic, when we started to initiate our pandemic plan, which every health plan has, we knew that the pandemic plan wasn't ready for this type of event. I mean, this was a very unique, once in a lifetime event. So the first thing that we did is make sure that we could have commitment from our associates regarding how much time would they need to put in order their lives and their families' lives so they could be safe. So quickly we surveyed the employees. We made sure that they wanted what they needed to be successful, not only here, but in their personal lives. And once we had their commitment, we decided to implement our strategy, which was twofold. One, to address the provider's needs, and then second, to address the member needs. While we appreciated all the work and all the communication from the state, we decided to move forward and not worry too much about the financial piece, but worry more about what could we do in our community to make sure that we could keep the healthcare delivery system going. And I know that kind of sounds, well, how can a health plan do that? Well, for us, because we're market leaders and because El Paso has a large share of the spend that is in healthcare is Medicaid and CHIP funding, we knew that our providers needed the resources from us to continue to provide services. So we quickly had forums with providers in the community, and we learned that a lot of them didn't have telehealth or telemedicine capabilities. So we did partner up with a local vendor who had created his own platform, and we actually helped subsidize the connection so that those members could have access to care. Then what we started to do is using our texting capabilities to make sure we can reach out to members. And once we had deployed a lot of the staff home, we actually started to do a lot of outreach to our high cost members so they can continue serving the members' needs. We also had to, remember that we might have had some patients out of town, because that happens in our service area because we have limited specialties in some of the critical areas. So we did all that work, make sure our patients were taken care of, and continue that work to make sure that people that were scheduled to go out of town, that it was an emergent situation, that we could still get that going. But overall, I think the community responded very well. Us being part of a healthcare delivery system really helped us get resources for us to really help providers and members in our community.
Excellent. Thank you, Frank. Well, I think we're ready for the next question. So we all know that plans need to contain inappropriate medical costs immediately without sacrificing the quality of care for their members. So the question here is, how do plans protect their business in this type of environment? And so Frank, I know you just went, but I think we started with you this time. A little bit, again, fresh content on the El Paso side. What's your thoughts?
This probably is the bigger area of challenge, because ultimately with all the unknowns that happened at the start of the pandemic, and with all the unknowns of what was okay to do and not to do, many of the health plans, in order to continue serving members, decided to forego some of those pending items and start providing help for the members. So now the challenge is, where is everybody going to end up, and what are the rules going to say, and then what are the audits going to say later on, right? So I think for us as a system, it's important that, and this word, and Nathan, we talked about this in the past, is payment integrity, and,
Yep.
and the quality checks that we're going to have now with telehealth and telemedicine, and the rules that should clear up what is the future of these programs and these type of service lines. So I think we have to work together to not just focus on, where could have we done better, but also how can we always be ahead of this as much as possible so we can deploy much faster. Because I think one of the challenges was that we were not, as a system, ready to tap on some of the urgent needs that the providers and members had. And I think that's a big lesson for all of us, that we have to work much closer together and more transparently together to make sure that all the payment integrity protocols and all the things that we want to do to make sure that the members serve, but that we don't spend money when we don't have to spend money, and we take care of the funding that's coming from the state, that there's much better communication for these types of events.
Makes a lot of sense. Appreciate that, Frank. Adolfo, why don't you go next?
Yeah, thank you. Thank you. I think what we saw, or I think we all experienced an interesting phenomenon, that the pandemic, in essence, fixed all the inappropriate utilization for us, as we saw, record declines in inpatient utilization, outpatient utilization. For us, even on the outpatient side, we saw about a 51% reduction in authorizations. On the emergency room use side, about a 25% reduction. And unfortunately, though, it also affected preventive care and maintenance visits, as we saw our PCP visits decline, and preventive services not being appropriately utilized. And so that was an unfortunate consequence. I think another unfortunate consequence is, as plans, and I think we all obviously responded to the federal and state requirements to relax certain provisions, whether it was on the pharmacy side and refill too soon edits, or whether it was on the clinical side with removing authorizations, or being less strict with or rigorous with authorizations on the inpatient side. We certainly did that to also help our system, since we are a provider-owned health plan, help Memorial Hermann's system manage for surge capacity, so that we could move our members through their system quick, and other patients through their system quickly into other levels of care to support the acute care for COVID-19 patients. But I think an unfortunate consequence of this has been that some individuals sometimes take advantage of someone's generosity. As we changed that, we did also see some opportunities for fraud, waste, and abuse. And I think one of the, as Frank was mentioning, the payment integrity, in working with Optum, and we work with Optum on payment integrity and fraud, waste, and abuse and SIU activities. We did see an uptick in laboratory utilizations, and what we discovered in working with our SIU investigators is that there are some unfortunate individuals, actors out there that a common scam right now in COVID-19 is on laboratory services, and billing small providers billing through large hospitals or hospitals to gain a larger reimbursement. And so we did see that. And we saw some of that nefarious activity, if you will, and quickly acted on that and put a stop to it through our systems in place on our claim side and through our SIU activities. So I think, it kind of hit us a number of ways, which on one hand, improving the utilization on the clinical side, but on the other hand, perhaps impacting, as I mentioned again, adversely financially, either through high cost cases and/or fraud, waste, and abuse.
For sure, for sure. Appreciate that. Stephanie, your thoughts?
Sure. So I think I would echo some of what both Frank and Dr. Valdez said. And, we definitely have focused on maintaining our payment integrity systems, while at the same time, we have had to implement various edits or workarounds as rules and regulations have changed. So we've been working hard to track those. I think the other thing that we're still learning here is, what that healthcare consumer behavior is really going to be during and when we get to the post-pandemic state. So, how they choose to access healthcare, I think is going to be we're going to have a new norm that we're going to be working with. And I think we're going to learn how to ensure we have, appropriate editing, payment integrity processes, et cetera, in place, especially with all of the testing and telehealth, telemedicine that we're likely going to see in the market. And then lots of, reporting, dashboards, leading metrics. So we continue to look at utilization and really try to understand proactively where it looks like we're trending and be able to adjust as changes happen and we all move through this process. And then, I think what Dr. Valdez mentioned about the testing companies was pretty interesting. They did sort of just appear overnight. And so, we do keep an eye out for those inappropriate billings and utilization as well.
Excellent. Appreciate that, Stephanie. So, to paraphrase, there seemed to be a consistent theme of relying on your strong partnerships with Optum. I just want to make sure we heard that in all of those. Shameless plug, I apologize. Well, let's head on to the next question. So taking a look at this, and I talk to each one of you as far as enrollment shifts that have been expected, what's occurring today, what you're expecting going forward. Just think a little bit from your organization's perspective. What disruption strategies do you have in place? How are you protecting yourself in these manners? Stephanie, let's start with you.
Sure. So, and I'm going to answer probably more from a Medicaid perspective. We have experienced a shift in enrollment that, as predicted, and as other Texas plans have as well, we have been able to flex our staffing levels and our processes and systems as we needed to. And it appears that most of what we have seen has really been member retention as we've extended eligibility windows for these individuals. The good news there was that we already had a lot of knowledge around the services and healthcare needs for these individuals. So it didn't really put sort of this larger administrative burden, on us yet relative to, being able to quickly assess needs for a new member. So, we did get new members, but we've also had a lot of members that just have extended their eligibility and have been able to continue their services with the plan. So that, I think, has been a little bit of a blessing for the plans.
Yeah, makes a lot of sense. Frank, your thoughts?
Yeah, similar to what Stephanie's saying, I think for the most part, most health plans are prepared, we're prepared for the growth. We understand the needs of our communities. We have been embedded in our communities for a long time. But what was different is really what the member needs were, right? So we saw what happened within 2 or 3 weeks of the pandemic, which was all these people needing resources, especially like in the food area, right? Where we saw these food banks explode and the need for food banks to be open more often than they are today. So I think as a health plan, one of the things that we do appreciate in working with the state is that flexibility for us to go beyond the scope of just covering the medical component of someone's needs, taking a holistic approach for the members' needs. And for us was to be active in the community, right? We decided as a health plan, and I'm very appreciative of my staff that was willing to help in the community, not just in the medical side, but also to do all these outreach events to give people food,
social needs,
social needs, social determinants of health. And I think that from what I've seen from the other health plans and some of the stories I've heard is something that we should be proud of, because I think most of us had that need to help these new members into our system understand that we were more than just the health plan to get you to the provider, that we could help you meet all your other needs, and that we were there to guide you through this challenging time.
Yeah, that makes a lot of sense. It's good perspective. Adolfo, what's go next?
Yeah, I think much like Stephanie and Frank have noted, certainly we did a lot of focus on assuring our members were whole, that we, were able to meet their needs, communicate effectively with them, provide them alternative sources of care, such as virtual care options, removing those barriers, removing all cost sharing to really drive utilization to those virtual services. But also we looked at the employer, from a commercial perspective on our side, we looked at the groups and employer groups. And I think, what we found is, in the system of healthcare, if you shock the system with a pandemic, the commercial side of the system kind of reacts, I think, the same for any shock to the system, and that it kind of has three reactions, right? Employer groups either drop coverage, or they reduce, the people covered, right? Or they reduce benefits. I think those are kind of what the arrows are in their quiver to try to manage the disruption and cost the best they can. And part of this was, as we saw the economic impact of the pandemic, certainly groups were very affected. As employees in all our healthcare systems were affected. They were furloughed, they were laid off, they were, reduced salaries. So all of that impacts a group's ability to provide coverage. And they want to provide that coverage for their employee. And so one way to maintain it is also to reduce benefits. What we did too is because we knew this was happening, and we insure many industries that are really in the small group space, 2, 3 employees, maybe 5. So therefore, they're also in the restaurant or hospitality industry, these smaller shops that were very negatively impacted by the economic fallout of the pandemic. And so we did a program of deferred premium payment for a specified time frame to help some of these groups manage their cash flow and cost with premium deferment. And we had about 10 groups that ended up, dropping coverage completely from our plan. But the most part, most people, were with us and maintained with us. But at the end of the day, we did see some impact, particularly on our HMO side of the business, with the loss of about 5% of our membership. So we did see some negative impacts. We also saw, of course, is the benefits, as I mentioned. And so we did see, plans asking for less rich benefits, and therefore, again, our ability to offer a product that has fewer benefits is, I'm glad we can provide the coverage, but it also, affects our revenue projections and finances as well. So a lot of the disruptive force mainly on the economic side of the pandemic that affected our ability on the commercial side to continue to provide coverage to our commercial members.
It makes a lot of sense. It's good perspective. I know the first ones were more Medicaid centric, but understand the commercial impacts was huge. So let's move on to the next one. And then we did get some questions from the audience. We'll, if you guys want to keep sending those in, we'll address those after we get to this last question. So as we take a look at this, as we navigate the new reality of handling the data and work generated by all aspects of your operational processes, enrollment, customer service, and claims processing, how does your organization plan to reduce overhead and increase operating efficiencies? Is this stretching your business more, making you look at things a little bit differently? Just thoughts and perspective on that. And Adolfo, why don't we start with you on this one?
Oh, great. Well, I think, again, just to follow up on that, just as I was thinking on that commercial impact, we project that, probably about 15% of our groups will see an attrition of about 15% in our membership. And so similarly on our side, I think there have been impacts to our workforce. We certainly are looking to see how do we reduce our SG&A, our administrative costs, and become more efficient and effective. So that means, looking at people working at the top end of their license, automating where we can, processes as much as possible, and then using and really leveraging virtual visits and or plans, perhaps even on the Medicare Advantage side. I know Stephanie maybe might want to comment on this too. Is we typically AEP, which is going to start in a few weeks here, it was always done almost face-to-face, brokers meeting with Medicare client, and working with them, or in the groups or in events, and that's gone. So we've shifted it all to a virtual space, and having to find brokers that are comfortable with that, platforms that can support that quickly. We've done that, but it's all moving into a virtual space. So but that also is teaching us some new tools about how can we become more efficient and reduce those administrative costs. But I do think that there's there's a challenge with that, obviously, where people want to see their broker face to face, or want to see who they're buying this coverage from. Similarly, on the provider relations side, although which is used to a heavy go to the office and meet face to face with the provider, all that has shifted to virtual. And so I think part of our challenge has been, how do you automate, how do you shift to virtual work and remote work, and then consequently or subsequently from that, it makes us look at our footprint. Do I need all this space and physical space, and would that help to reduce costs as well? So I think we're, from a number of ways, on the administrative cost side, we're looking at that, but we're also trying to flex and say, well, how can we leverage this into new products and designs that are more virtually based, that can support members' needs more efficiently and effectively at a lower net cost.
Absolutely. Yeah. And I echo everything you said there. That's been a lot of the questions we get from our customers as well. I know, Frank, we've actually touched on those topics. Additional perspective, definitely on the telehealth side. I know you guys done a lot there. Your thoughts?
Yeah, I think overall what this episode taught us, and especially for us, we had this whole business plan where we were gonna build a new building and spend on all this brick and mortar, and this episode really made us stop and rethink our strategy, and now we decided to stay in the building, adjust the building to make sure that we can easily either fully have 100% of the staff in the building, or 100% of the staff at home. And we decided to make that shift in their investment. I think the other thing that we as health plans have to do is invest in our workforce, because I think as these times come, we have to depend on people to do more with less supervision, especially when we start sending a lot of people to work from home. So how do we use technology, and how do we use resources to make sure that our folks in the health plan have all the resources they need, so we can keep the same level of care and attention to our members during these challenging times. So I think you're gonna see a concerted effort from many of the health plans to find the right partners to make sure that whatever the virtual reality is gonna be here from this point on is something that we try to stay ahead of and actually innovate it, so we can have success stories like we see in other industries.
Great. Makes a lot of sense. Stephanie, you want to go next?
Sure. So, I would echo a lot of what Dr. Valdez and Frank said again as well. We are all going to be looking at our physical footprints during and after this. I also think we need to expect a shift in the workforce expectations and an impact to our talent pool. We all compete for the same managed care resources. And I think as this remote workforce starts to grow, it does create a new opportunity and market situation for our talent pools. The other thing, and Dr. Valdez touched on this relative to just consumer engagement and enrollment. Our enrollment season for Medicare and the individual market is kicking off here in a couple of weeks. It'll be interesting to have this conversation on January 1st and see what we all learn. But, you know, I think everything's going virtual and curbside. And we've been able to transition a lot of our, or really all of our agent and consumer facing meetings to a virtual type platform. And what's really been interesting and the thing that our customers are teaching us as we move through this process is that they become more comfortable with it the more you do it. So as we host things like virtual baby showers, we used to do those face-to-face. We'd have 100+ moms show up, and moving that to virtual, the more you do it, the more your engagement goes up on each session and you get more and more moms logging in. The other thing is they ask more questions. And, you know, I think part of that is just it probably provides a comfortable space for them to be able to sort of anonymously submit a question. And so we're enjoying getting to have those types of interactions and engagement with our members. And we are learning from them as they engage with us across these virtual and digital platforms in this journey. So that's, you know, really where I think, you know, in the winter or coming out of this enrollment season, I think we're going to have a lot of, you know, learnings that we'll be able to leverage going forward. All more efficient, definitely.
More efficient. Yeah, a lot of consistent themes there, and it's definitely pushed the industry as a whole. So what we have now is we've got some questions that have been sent in. Please respond in the Q&A section. It seems like some of them came in the chat section. We're going to go through a few of those right now. We've got a little bit more time and just kind of do some live Q&A. So if you have anything else, if you want to send them in, that would be great. So first one, anonymous attendee. What issues have you experienced in scaling or creating virtual experiences for your members? Now, we touched on this a little bit in the last question, but I know there's probably a little bit more focus in this one. Stephanie, since you left off, and I know you touched on this, do you want to answer this one first? Sure.
So, I will say from a provider perspective, when March happened, and we did go to pretty much, you know, all virtual care. We did have to set up a special sort of unique tailored unit to help patients use our BSW app and be able to connect to a provider if they were indeed having trouble. So we have, you know, implemented additional support mechanisms for consumers and patients. So that was one thing that I think helped. The other is from a health plan perspective, we have had, you know, similar support mechanisms in place. So, you know, on a webinar, we typically will have somewhere between maybe 8 to 10 people that are working that webinar to answer questions, provide technical support if needed. And again, you know, one of the things our members continue to teach us is that the more we do it, the more they will show up. And so it has been a learning curve, but we continue to get better at it as we go.
Excellent. Frank, do you want to touch on that one next?
Sure. I think from a Texas perspective, one of the things that continues to be a challenge, especially in rural areas, is broadband. You know, yeah. How do we connect with everyone when not everyone has internet connection? And I think that's a state issue that we all can contribute to the solution, but I think it's going to take a statewide effort to improve that. What we discovered here, even in El Paso, is the city is growing pretty fast, and some of the areas where there's still not good internet service, that made it challenging for providers and members to keep connected. So we had to depend on the phone and cell phone numbers to be to continue that communication channel. So I think for the most part, when this happened, a lot of the providers did feel the panic and started closing offices. And how do we go back and make sure that they reopen, or how do we transfer those patients to other providers that were willing to help with those patients? And I think, for us, having a hospital district support us with clinics across the city really helped us make sure that our members continue to have that touch point with providers. But I mean, overall, I think broadband is an issue for Texas in these pandemic situations.
That makes a lot of sense. Adolfo, round it out.
Yeah, I think well said by Stephanie and Frank. But it's interesting, Frank, as you mentioned, providers and the issues. One of the things we saw, which caught us by surprise, actually, was because there was such a shift to virtual care. Many of our providers, and some of these were maybe more national type, retail-oriented urgent care sites, decided to close their brick and mortar sites and fully move to a virtual model, which then had implications for us in our network, and say, hey, wait a second, now we thought we used to have this many urgent care providers, but now it's been reduced to this many because they physically closed their shop. And what is that impact in the future going to look like? Is that going to continue? And which may have a plus or minus, but it did make our PR team and network team wonder, well, how are we going to manage and build networks in the future to support our products and our service areas, and most importantly our members, of course. And so that was an interesting wrinkle that we're still trying to assess, is, well, what is that impact of providers actually closing their brick and mortar and just moving to virtual and a singular virtual site, so to speak, and which may limit access, especially, as Frank pointed out, if you do not have broadband or internet access to that. I think the other piece is, as Stephanie said, and I remember this when I was with Baylor Scott White, they have a wonderful app. I'm jealous, but I think our challenge, I remember then, and same with ours on the Memorial Hermann side, is as particularly for our seniors in our Medicare Advantage product, is really having to do a lot of hand holding and training to teach them how to use the technology and the app so that they get adept at it and able to use it effectively for their care. And so I think we've been doing much more hands-on through customer service and through our outreach efforts to do that and support our members. But that's a challenge, and we've seen an increase. Typically we see telemedicine, virtual visit utilization in the 2.5% for Medicare Advantage members, but we certainly have seen a significant increase, 50%, 100% or more increase in the utilization of our telemedicine virtual services in our Medicare population. So I think that technology transfer, that knowledge transfer is working, and members are beginning to learn how to adapt to the virtual technology and use it.
Makes sense. So we've had a few more questions come in. So I'm going to try to say this one appropriately. So it says, do y'all see keeping any of these solutions long-term? If so, which ones? So, are these trends going to continue? Will this permanently change? I think we've talked a little bit about that already, but just, your thoughts on keeping these solutions long-term. Maybe Adolfo, let's start with you this time.
Yeah, I think it's a great question, and it's making us all, at least in my health plan, and I'm sure everyone on the panel and beyond these walls are thinking about it. How do we, in fact, literally, I just had a conversation with one of our other medical directors at the system level, looking at virtual health opportunities and saying, how do we create a plan around this? Certainly Oscar Health has some virtual plans, and I think it's worthwhile to explore and see what would that look like in a Houston market, and how and would that sell, and would that provide the care that members expect and need. So I think we're exploring all of these options and doing that ROI calculation and saying, is it going to benefit my member and benefit our organization? So I think it's hard to say. We're still exploring and evaluating.
Makes sense. Stephanie.
Yeah, so, I would agree with what Dr. Valdez said, and sort of to talk about the Medicare Advantage membership a little bit. We do have pretty high engagement from our Medicare Advantage members. And, you know, the thing is they really still, to a great degree, prefer a phone call with a provider. So they may not want to use a video option or an e-visit type option. They really like phone calls. And so, you know, I think two things. One is we're still going to have to figure out, and we're still learning what consumers are really going to want in healthcare after this is over. The other is I think, you know, the more that we can help promote digital and virtual care and care at home, you know, I think the more we prepare for our future, because I really don't see that, that, you know, we're going to return to the same normal. It's going to be some new normal. And to Dr. Valdez's point, we're still figuring out what that is to a great degree.
Makes sense. Makes sense. Frank?
Yeah, I think it's going to be a combination, Nathan, of a hybrid of taking some of these things that have occurred. Yeah. And for us is, I think we all saw this coming, because even a doctor 20 years ago told me at some point the consumer is going to want drive-through medicine. And I think the episode of COVID has brought that to a closer stage. So it's how we're going to react to that situation. And I think for us is what we discovered in the Medicaid population, similar to what Stephanie was saying, the baby showers, actually our attendance went up when we did the first baby shower through the video software, because it's a younger population. So some of us that are a little older now and are from a different generation have to accept that this is a new reality, and this is where the younger generations live. And I understand about the older population, but the younger population that's mostly in our Medicaid and CHIP demographics like this type of intervention. And it's going to be up to us to make it a quality-based intervention. And I think that's where the partnerships come into play, and the transparency of best practices among health plans, and working with the state to make sure that we make this a solution that works for this new generations that are coming up.
Oh, that makes sense. And it actually, so this directly ties to the next question coming in. So this will be our last one. Let's try to keep it to 30, 45 seconds. We're running a little bit low on time. But last question here. So we've talked a lot, or touched on a lot of the positives of virtual care. You know, the baby shower example keeps coming up. But as we move into the winter time and continued COVID concerns, you know, are we worried about any kind of negative aspects? You know, isolation issues. You know, do you guys have any efforts underway to figure out how to attack those types of things, members, kind of proactively engaging them and preventing these types of issues? So just kind of more of the aspects of what we've seen positive, obviously, but on the negative side, what are we doing on isolation? So Frank, I'll start with you on this one. Like you said, try to keep it to 30, 45 seconds. Do a quick fire here.
I think for us, we're now accepting face-to-face and walk-ins into our plan. We're taking all the precautions necessary, and we still believe that face-to-face can be removed from the system because of isolation. So we are looking for creative ways for us to reach members through touchless points of conversations and face-to-face interactions.
Makes sense. Thanks, Frank. Stephanie.
Yeah, so agree with Frank. Also, I think one of the things that we have really scaled up and will continue to do is outreach and assessments for things like isolation or any real sort of social determinant of health issue, and then making sure we have good partnerships locally in these communities to help these individuals get their needs met and the services, you know, whatever that may be. So again, and I kind of come back to digital, there's a lot of neat sort of innovations and opportunities out there now to help connect more often, get more information from your member. to really help inform the plan where there's a need or a potential need coming. And so I think we're going to see a lot of focus in that area.
That makes sense. Adolfo.
Yeah, I think there's a lot of opportunity. We know, social isolation is an independent risk factor for premature death in our Medicare Advantage population and our elderly.
Right.
It's interesting. I was just contemplating, as you asked that, a pilot project by my wife and her Girl Scout troop, which was to basically we were calling it Generation Connect, where we had their Girl Scouts create a script together with an adult calling on seniors to just talk, to ask a series of questions. And it was really interesting how, I wish I told her we need to make this into a nonprofit or something, but we aren't there yet. but it was excellent in that everybody wanted to talk. Nobody ever said no. And they like to talk about themselves. And there's different questions you could ask that are, of course, you want to stay away from the politics and some things, but it was just fascinating to watch and watch a young generation, Girl Scouts connecting with an elderly generation just to communicate and connect. And I think there's a lot of potential in doing that. I'm certainly going to explore with our health plan, how do we do something similar or partner with the group perhaps and a community-based organization to support our membership.
That's awesome.
Nathan, before we go, I would have to mention this, a lot of the health plans, including ours, are already doing case management through video to address isolation. And I think that's something that we have to work better with the state to understand that it is an effective way to communicate with folks. And it's a good way to assess people's homes through video, because that gives them a sense of they're talking to someone live in these trying times and making sure that we take care of those patients.
No, I really like that. That's a very important point, Frank. So with that said, we're going to wrap for today. We want to thank TAP for hosting this panelist group. Really, really appreciate the conversation. Distinguished guests, panelists, thank you very much for all your answers. Hopefully you guys enjoyed all the perspectives we gave on this presentation. So thanks, everybody. On to your next one.
Thank you very much.
Thank you.